Penicillin, a comprehensive overview. 1. Discovery and history. Discovery. In 1928, Scottish scientist Alexander Fleming observed that Penicillium notatum mold contaminated his Staphylococcus culture plates, inhibiting bacterial growth. He coined the term penicillin for the antibacterial substance. Development. Howard Florey and Ernst Chain at Oxford University purified penicillin and demonstrated its clinical efficacy in the 1940s. Mass production began during World War II, notably using deep tank fermentation techniques in the US and UK, saving countless soldiers' lives. Nobel Prize. Fleming, Florey, and Chain received the 1945 Nobel Prize in Physiology or Medicine. 2. Mechanism of action. Target. Penicillin disrupts bacterial cell wall synthesis by inhibiting penicillin-binding proteins, PBPs, enzymes critical for cross-linking peptidoglycan strands. Effect. Without a functional cell wall, bacteria lyse due to osmotic pressure. Effective primarily against gram-positive bacteria, for example, Streptococcus, Staphylococcus, due to their thick peptidoglycan layer. 3. Types of penicillin. Natural penicillins. Penicillin G, intravenous/intramuscular, acid labile. Penicillin V, oral, acid stable. Semi-synthetic penicillins, aminopenicillins, for example, ampicillin, amoxicillin, broader spectrum, including some gram-negative bacteria. Beta-lactam resistant penicillins, for example, methicillin, oxacillin, resist enzymatic degradation. Extended spectrum penicillins, for example, piperacillin, combined with beta-lactam inhibitors, for example, clavulanic acid, to enhance efficacy. 4. Clinical uses. Treats infections caused by susceptible bacteria, streptococcal pharyngitis, syphilis, meningitis, endocarditis, and skin infections. Revolutionized treatment of previously fatal diseases, for example, syphilis, bacterial pneumonia. 5. Side effects and allergies. Allergic reactions range from rash, common, to anaphylaxis, rare. Cross-reactivity with cephalosporins occurs in 10% of cases. Gastrointestinal issues, nausea, diarrhea. Rare toxicity, neurotoxicity, seizures, at high doses or intrathecal administration. 6. Resistance mechanisms. Beta-lactam production, enzymes hydrolyze penicillin's beta-lactam ring. Addressed with inhibitors, for example, clavulanic acid. Altered PBPs, modified target proteins reduce drug binding, for example, MRSA's resistance to methicillin. Efflux pumps/reduced permeability, limits drug uptake, particularly in gram-negative bacteria. 7. Production and administration. Fermentation. Penicillium molds produce the core structure, modified chemically for semi-synthetics. Storage. Some require refrigeration, others are stable as powders for reconstitution. Routes. 4. IM, or oral, depending on formulation. 8. Drug interactions and considerations. Interactions may reduce contraceptive efficacy, caution with methotrexate, renal excretion. Competition. Renal excretion, dose adjustments needed in renal impairment. 9. Impact and legacy. Public health marked the antibiotic era, drastically reducing mortality from infections and increasing life expectancy. Resistance challenges. Overuse has led to resistance, necessitating newer antibiotics and stewardship programs. 10. Alternatives for allergic patients. Macrolides, for example, erythromycin, cephalosporins, with caution, or vancomycin for severe infections. Conclusion. Penicillin remains a cornerstone of antimicrobial therapy despite resistance challenges. Its discovery underscores the importance of serendipity and collaboration in science, transforming medicine and saving millions of lives. Responsible use is critical to preserving its efficacy for future generations.